Welcome to Creating New Healthcare. We have with us today an expert in weight management and nutrition, and Dr. Laure DeMattia, who I've just spent a little while talking to, and then I realized we weren't recording, so we're here now recording. Laure, do you mind if I call you Laure?
Yes.
Tell us a little bit about your background, because I just think you have a very fascinating background, and also you have your own story. So you're a professional and an expert, but this is also very personal to you as well.
Well, Dr. Neuwirth, thank you so much for having me. And is it okay if I call you Zeb?
Yes, please do.
All right. Thank you so much. So I have been in obesity medicine even before it was, I guess, called that. So I started in the late 90s in med school, pursuing how to learn how to help patients who are struggling with obesity, because I was learning how not to be a physician caring for patients with obesity by my the protocols that were out and the knowledge that most physicians are not taught, and even today it's still a limited kind of discussion in medical school, which blows my mind. So 1998, NIH came out with the adult treatment guidelines. I said, oh boy, I've got to go study with them. And they redirected me to Dr. Robert Kushner at Northwestern because I was in Chicago. And so I started in medical school learning with their group. And so I watched bariatric surgery go from all open procedures to laparoscopic in a very short period of time, late 90s into early 2000, because I ended up doing my residency at Northwestern. And then I went on, because I'm family medicine, I went to work at the Medical College of Wisconsin and helped with the New Kids program, which was pediatric obesity care. And so that's where I started my, cut my teeth, was in the pediatric obesity world, and then have kind of focused on adult obesity since then. And myself, I am a patient myself. I have lived experience with obesity my whole life, including pediatrics. And so I wanted to be the doctor that I probably should have met a long time ago.
Oh my God, that is absolutely beautiful. I've never heard anyone say that. I wanted to be the doctor that I should have met or wished I'd met a long time ago. That's an amazing, you're hired. Okay. I would hire you. That's awesome. So this is very personal for you. You really,
It is.
I imagine you can really empathize with your patients.
Whether it's good or bad, I will cry with my patients about the maltreatment that they've experienced over the decades of life. I really worked hard to create a safe, shame-free experience. I didn't always get it right, and I have no problem acknowledging when I screw up. And so that authenticity, I think, just the realness of I'm in the boat with you. I am still having to navigate this. Just put a lot of people at ease because of how much bias exists still to today.
Mm-hmm. Mm-hmm. Can you, I mean, you asked me before we got on, you said, to me, you looked at my background and you said, why are you talking about this? Because this isn't exactly, and I think the short answer is this issue is, it's rampant, right? I mean, obesity is, what's the percentage? I mean, I read the other day, overweight, the percentage of Americans who are overweight or obese is over 70%.
So I will take it a step a little in a different direction. By 2035, Please. Half of the world will be struggling with the disease of obesity, if we continue on the current trajectory that we're on. And it's not because people aren't trying. Like, people are trying more than ever to address this disease. And part of why I've stepped outside of my comfort zone, because I'm fine talking one-on-one, but I do not I was in academics, and, that's a really long approach to getting change to occur. You know, you have to do the research and then you have to present, like publish, present.
Mhm. Mhm.
And I was not cut out for that. And presenting my findings, it has always been a struggle. And so I felt like I am the patient's doctor. You know, like I really
Yeah.
want to
Yeah.
treat this and help cut through so much of the noise. But what's
Mhm.
happened recently, like since 21, I would say, I feel like with the, it was in 21 is when
Mhm.
Wegovy was released. And we hadn't had a new obesity medication since 2013, which is wild. But that is just how the cookie crumbles. And then in 23, Manjaro was released, and we knew that Zepbound was coming. And so, but I would say since 21, I have been fighting with people, patients that are not who I intended to be treating. There are a lot of people who are seeking care that are not what I would say qualify, for the treatment. And I am really wanting to work with people who feel like a prisoner in their body. That's who I feel like I'm called to care for. But I kept on getting more and more people who barely met criteria or didn't meet criteria and wanted to see what we could do. And I understand everyone wants to pursue health, and I'm not against that. I just feel like, especially the GLP-1s, there are risks, to taking that medicine. And I feel like there is such an intense interest in that family of medication because it's so effective, that people are kind of like throwing caution to the wind sometimes. And, it's the risk benefit ratio. Like, what are we getting out of treating, this? And maybe it's someone who has overweight, but no other health conditions that are putting them
Yeah.
at risk.
So this is really, I'm really glad you're taking it in this direction. And so I really want to double click on this, dive into this with you.
Yeah.
So I'm getting so, I mean, you use the word, I think something about fighting with patients. So, I mean, you're basically, it sounds to me, I'm getting this image that you are literally saying to a lot of folks, either you don't need this or it's not indicated for you. It's not, it's not in your best interest to take it. And so could you tell us, as we're listening to you as an expert, a real expert, clinician expert in this field, who are these medications for? Who are they in what situations are they indicated? Who are they not indicated for? And what are your concerns about the side effects? Because I will tell you, as I listen, everyone downplays the side effects. And I, for one, I will tell you, for myself, my family, I'm very concerned about the side effects. And so who is it indicated for? Who is it not indicated for? Yeah, could you start with that, and then yeah, the side
I
effects.
guess I just want to frame it for people. I am taking a GLP-1. I
Okay.
had bariatric surgery in 2019. I am not against GLP-1s in any way, shape, or form, but I just want people to understand the reality of being on something that could cause you pancreatitis or could cause you to have gallstones and need emergent surgery. Gastroparesis is not been, like, we're concerned enough,
Mhm.
or I'm concerned enough about gastroparesis that I mention it to my patients,
Mhm.
because I just want them to be aware that there have been claims. We don't have like a study saying gastroparesis is higher. I do feel like gastroparesis is associated with diabetes more. And so is it
Mhm.
just like a red herring? But I want people to not come back and say, you didn't tell me about this and now I
Right,
can't eat, which would be
right.
horrible. And so, malnourishment. I mean, there's
Mhm.
been some recent studies looking at, malnourishment,
Mhm.
because it is so effective. And so
Mhm.
we are not trying to get rid of hunger. We're trying to help people
Mhm.
who have
Right.
uncontrollable hunger manage that. And so that's where, like, there's a lot of, I love the term food noise. I think a lot of people
Right.
weren't aware of that. They felt like this is just
Mm.
how my body is. And I parallel this when someone gets on a GLP-1 and it's much more quiet compared to like attention deficit when someone is treated with a stimulant and they're like, this is how other people's brains work,
Mm.
and they were untreated for so long and trying to manage life because so many people have implicit weight bias against themselves. And so when they get on an effective treatment, and I'm trying to say, hey, this isn't a jump start. Like, this is something that likely to really effectively manage this disease, you're likely going to need some sort of treatment long term. And so there's so many people who just want to try it for a couple months. And the literature says
Mm.
most people don't stay on it very long. And
Right.
I don't really know if it's because they're not getting support, they're not being
Right.
educated. I don't know what the reason
Wait,
is.
can I ask you
Okay,
about that? So,
yeah,
so the literature says most people drop it after a few
within 6 months.
within 6 months. And what does the literature say about what happens to their weight? Because in my mind, I'm thinking, I would come to you and I'd say, Dr. DeMattia, I want it for 3 months or 6 months. And then, just to lose those 20 pounds or 30 pounds or whatever it is, then I'm going to stop it. What does the literature tell us about whether that's going to work for me?
Well, so Surmount 4 trial showed that, stopping Zepbound after I think it was 64 weeks, shock and dismay, people regained weight. And I'm like, why are we wasting money? Like, that is known, like that is not a surprise. It'd be like saying, oh, I'm going to get you to goal on your A1C with insulin, and then I'm going to stop your insulin. And why are you not maintaining that A1C that we got to?
Wow.
And blood pressure, diabetes,
Right.
cholesterol, like all of these disease states are in the same boat, meaning they're chronic. They all do better with appropriate diet and exercise
Mhm.
activity, but very few people can manage to treat the disease state with just diet and exercise. But for some reason, I feel like obesity is this like orphan over here
Oh,
where
interesting.
there's an expectation that it's going to be different.
Right. So if I start one of these GLP-1s, I have to really understand this is for the long run. This is
So, I mean, it's not saying once you start it, you have to stay on it forever and ever. Like, of course, if you don't tolerate it, if you find that you have
right.
negative side effects, obviously we're going to stop it. But I'm saying the people who come with the idea of I just want to jumpstart doc and then expect to maintain, and this is where I feel like, are you familiar with the idea of set point theory?
No.
Okay, so I don't like, it's not clearly like this is the way, but set point is basically the idea that the body wants to maintain a certain space. And I say we have set points for our heart rate, our blood pressure,
Mm.
our respirations, our weight, and the body doesn't want to waste energy trying to like chase these like wild swings, right? And so most patients that I work with, their body weight can swing 5, 10 pounds either way, and the system doesn't go on high alert. But when someone says, usually 10% seems to be like the cutoff for most people. If they push it past 10%, the body starts to say, are you sick? Are you hurt? Let me help. And I'm going to slow down I'm going to increase your hunger. I'm going to make you more tired. You don't listen to that, which is what most of my patients don't. They're like got the blinders on, they're going for it. And then the system says, okay, well, we're going to die. It's an overreaction, but it's trying to keep us alive. And that's from many, many thousands of years of human existence. Famine, injury, illness is what would kill us. And so we have a lot more safety backup around too much weight loss. It does not seem to have the same kind of protection against too much weight gain. And so that, when you get past that, the checkmate that the body does is it will slow down your metabolic rate. So people, like I had a guy who lost 200 pounds without seeing me, and Why would he come to see me if he lost 200 pounds on his own, right? Because he was doing all the things, the diet, the exercise
Mm.
that helped him get that 200 pounds off. And yet he was regaining weight. And so the body was like, I don't know why his body let him get that far, down the river, but it
Wow.
did. And I would say he is unusual. Like there's something different and he should be studied because he is different. Most people, it's like 10% and the system says, what's going on? And I'm one of those, I'm less than 10%. And so, I mean, I would
Wow.
do wild things to try and get my body. And my own example, after bariatric surgery, you're getting 2 shakes a day, like your 60 grams of protein, that's less than 500 calories. And I did not lose any weight in
Oh,
that
wow.
first 6 weeks because I was in so much pain. I had something happen with my back. I couldn't sleep. I couldn't stand still. I couldn't sit still. I was in constant pain and I
Mm.
couldn't take my typical like ibuprofen or NSAIDs were kind of like what helped me to get through the day a lot. And because I just had surgery, I couldn't do that. I couldn't take steroids. I couldn't, so once my pain got better, at that point, I was eating more. And then my body allowed me to lose weight. And so for
Mm.
me, I have given up on, like, I think I know, but I still don't know, even though I've
Right.
experienced it personally. I've watched thousands of patients go through so many different experiences. And so I just always am like, let's figure this out for you. And that's where I'm at.
So, so are you saying, so there's this set point, right? You're saying, so body starts to lose weight and says, hey, something's wrong here. I'm going to try to keep this weight on. Um, does, how does the GLP-1 affect the set point? Does it reset the set point at a lower weight? No.
Not that I've seen.
Okay.
And I mean, I had a lady who, sometimes insurances change their mind like in the middle of the year and stop covering GLP-1s. And so I think I was seeing her at 3 or 4 months without GLP-1s. And she was like, I'm cured. This is amazing. Like, I'm still not having the same level of
Oh,
hunger that I did before. I'm maintaining my weight loss. This is awesome. I'm like, okay, cool. Like, let's see
right.
what happens. And by month 5, her hunger was so loud,
Yeah.
she would like call me crying, and I was like,
Okay.
it's not going to stay like that. It's like an
Right.
overreaction. I don't
Right.
know why you had 3, 4 months of like really quieting, it.
Yeah.
I don't have an explanation of why
So,
that worked for her.
so what I'm understanding is that these medications allow you to go past your set point, below your set point without the body rebelling. And
Yes. And so what is so interesting, I would say the loudest symptom control that I hear is like the fullness. People are so full with
mm,
so much less needing to eat to be full. So satiation is different than hunger. And
mm,
I feel like before GLP-1s were so popular, I would really try to figure out, what are you struggling with? Is it hunger? Is it fullness? Is it impulsive
mm,
eating, like, or emotional
mm,
eating? Or is it all three? And I feel like for so many people that the GLP-1s take care of all of those 3 categories. And so
wow.
it's not for everyone, but a lot of people, I would say fullness is the biggest. Like, they're like, oh my gosh, I am so full. I don't want to snack in between meals. I'm forgetting to eat, which anyone who has struggled with their weight, they always say, I've never forgotten to eat a meal. I'm like, well, now you have. And so it's
Wow.
very different
So,
experience.
so hunger, satiation, and that, does it actually affect the impulsive, that food
It
noise thing?
does.
Yeah.
So I had this one guy who was drinking 15 beers a day. And he had diabetes. And so we were going to use Manjaro. And I said, you're saying you want to improve all aspects of health. I'm going to say, can we reduce your caloric intake from the beer? I didn't want him to go into withdrawal. So I was like, let's get down to
Mm,
10 beers a day.
mm,
And that was my only recommendation about the alcohol. Within 3 months, he was not drinking at all. And I kept on
wow.
like
Mm.
What's going on? And he's like, I just am not interested in drinking like I was before. I'm
Yeah.
like, wow. So it is being studied for that right now.
So one last question about the GLP. Well, actually two. One is the side effect that worries me the most is the sarcopenia, the muscle loss. And what do
Mhm.
you say about that?
So I would say that any form of weight loss
Mm,
causes muscle loss.
mm,
And I would say bariatric surgery and GLP-1s, it's the most apparent because they are the most
mm,
effective tools. And so everyone's very concerned about that. And I would say, but it's any form of weight loss is going to
mm.
cause muscle loss. So you have to counteract that with strength training, making sure you're meeting your protein needs. And that's where, like, yes, people can shut off their hunger completely with GLP-1s. And that is not our goal. Like that is not the
Right,
goal. But
right.
that is what people really like. They like that a
Yes.
lot.
Yeah. Um, quick question.
Yes.
How much protein?
So I'm probably more conservative than some of my colleagues, meaning like there's a lot of hype about, patients will come in and say, oh, I'm getting 120 grams of protein. And I'm like, how are you getting 120 grams of protein? Oh, I'm drinking 3 shakes a day. Do I think that you're absorbing that the same
Mm,
and it's utilized in the same way as if you were getting 120 grams of multiple different sources? No. And so there's some argument that we don't absorb more than 15 grams at an eating episode. And so
mm,
to say, I shot down 30 grams in 10 minutes, are you going to take
yeah.
all that in and use it? I don't
Mm,
know. And then to add on, every person is different and their
mm,
physiology kind of is expressing differently. And so it's a wild, like ride
yeah.
because I just feel like obesity is a very large word like cancer. There's so many subtypes of cancer. We can get tissue and then we can say, okay, it's this form. We don't have that.
Mm,
And like 2015, 16, there was a lot of interest in trying to subtype obesity,
mm,
and then it just
mm.
died. Like I don't
Interesting.
really know what the
Interesting.
reasoning
Yeah.
of why that information stopped
Yeah.
being trying to sort out, except that it didn't seem to make that big of a difference. But I just feel like there is the hunger versus satiation versus
Yeah.
impulse
Yeah.
type or the mixed type. And so if I could know, like most people know about themselves, but some people don't. They're like, I don't know what you're talking about. And then I'll ask them to start paying attention. Like, okay, could you try to figure that
Mm,
out about yourself? Because again, that implicit weight bias so much,
mm,
people like judge themselves and like kind of suppress, what, you know, if they really enjoy eating something, they get mad at themselves about it. And I'm like, no,
yeah.
it's supposed to be pleasurable, like sex.
Yeah. You have a method, the CHEF.
The
Could
chef
you?
framework it
Yes.
came before GLP-1s got so exciting. I mean, GLP-1s have been around, since 2005, but it was
Mm,
really just diabetes initially. And then 2013 is the first time the FDA approved GLP-1s for obesity treatment. I definitely was an early adopter because I could see how much it was helping people and there was research and all that stuff. So anyway, I was trying to differentiate, are you struggling with craving? Is it your hunger
mm,
that's the trouble? So C is craving, H is hunger, E is energy, and F is fullness. And so the E is really like, I want people to pay attention to how food either energizes you or depletes you. Do you feel
mm,
like you need to take a nap after you eat X? Then that probably isn't okay to eat alone. You might need to have a mixed meal if you want to incorporate that into.
mm,
So, like pasta for me, I'm Italian. Pasta is a big part of my culture, but I figured out for me, pasta is a very, very no go. Like, not only am I hungrier within an hour and a half, of eating it, I'm hungrier for days after eating it. And
Interesting.
I've always been functionally hypoglycemic. And so insulin resistance, and, I think it just made craving for sweet and savory carbs louder for
Mm.
me. And so I love insalata caprese, which is mozzarella, tomato, olive oil, balsamic, basil. And that's how I get my Italian on now. And if I'm going to have pasta, I'm going to take the hit and know that it's probably going to mess with me for a couple days. And sometimes I do it. Sometimes it's like, it's not worth it.
I love your E. That's something folks don't really think about. I don't really think about it. But now that you say it, you got me thinking. I'm like now going back in my mind and saying, oh, she's right. There are foods that I'm like, well, I feel great and I've got this energy. And then there are foods that like either immediately or the next day, I'm feeling sluggish or tired. And so I'm going to use your E quite a bit now. Thank you for that.
You're welcome.
Um, a couple of quick questions because I know we're over time here.
Okay.
Um, your what are your thoughts about behavior change? Because there's the information, the education, the recommendation you make in the office, but then the real work happens where people are actually living and working and playing. So how do you cross that bridge? Do you have a method or approach to, or how do you help people with behavior? Or is it, well, now the GLP-1 sort of do that, but because they affect all those things you were talking about. But what's your thought about behavior change and sustainable behavior change, really?
Well, so I like to challenge people to come up with a goal that is aligned with their values. So a lot of times people will talk about, I would like to have freedom of movement. I want to travel without pain. I want to be able to go for a hike or a walk without pain. And so okay, that's the
Mm,
goal. And so what do we need to do to help make that a reality? And so it's used in disordered eating,
mm,
value-based treatment, and
mm,
it's kind of a borrowing it from them to
yeah,
try and help patients push through when it's not pleasant and irritating. So like I don't like flossing my teeth. And I use this as an example with my patients. Like I'm totally grossed out by it, but I know
mm,
how important it is. And I don't like doing it, but I like the outcome. I like that I don't have gum disease. And so I'm doing this behavior on a daily basis, and I don't like it on a daily basis, but I like the long-term outcome. And so we don't have to like what we're doing, but
mm,
we have to use our executive functioning to decide, okay, this is more important than that discomfort. And
mm,
and then the other is like I had a very small solo practice earlier in my career, and my daughter was like 2, and I was working in the ER and trying to build this practice. And I knew that if I didn't make it, like I couldn't wiggle out of physical activity. So I ended up partnering with a personal trainer and did group training for my patients. And I would literally cry in the car before going because I was so tired and I just wanted to rest. And I'd put my big girl panties on and go in there and laugh my way through the workout and get a second wind. And I'm like, why were you so upset? You're like, look, you have a good
yeah,
outcome. But even with all that knowledge, like I'm just saying our brain is about survival. And like that very moment is saying that's a bad idea. Like that is not good for you.
yes, yeah.
And so it's going to come up with all these resistant lines and reasons that don't do that. And you have to like come up with a bigger why to be able to get
Yeah,
over that.
that's fantastic. I love you're tying the motivation, you're tying it to this. What is it, the thing, why are you doing this? Is it that you want out of this? And that's your driver. So
Yep.
you're not imposing that on the individual. You're actually asking them. So it's really an intrinsic motivator that they share with you and that you use. That's brilliant. That's one of the best responses I've heard. Um, Oh, Mike, we could talk about that part for so long. I mean, I think the whole issue of environment, who you hang around with, that whole kind of other, parts too. But that's a great, really great piece of advice. Um, any final word you want to share with folks who are listening? This has been fantastic. I've learned so much. Thank you.
You're so welcome. I want women to stop pursuing thinness. I want women to pursue their health and their well-being and not put themselves like societally, generationally, culturally, religiously, we get the message that put others before yourself. Like we are very much rewarded for that. And so I'm a big rebel and I'm going to try and get people to stop like just going with that. That is not okay. And before I was a mom myself, I joke or people would laugh at me when I would try to say, I need you to put yourself first. And then I became a mom and okay, I understand like that's not going to work, but I need you to put yourself on the same playing field as your kid. And so I often talk about mothering yourself with
Mm,
people because they're going to make sure that their kid gets a good bedtime. They're going to make sure that their kid has healthy snacks. They're going to make sure that their kid doesn't go to school hungry. And I
mm,
just want the same, like you are enough and worthy of self-care. Self-care is not selfish is probably one of my biggest lines to people.
mm.
And so I just want women to really pursue their health and well-being than being thin.
Wow, that is awesome. I'm going to share that with others. I think that's brilliant. Mother yourself, um, and yeah, and self care is not selfish. Those are two things. Mother yourself and self care is not selfish. Thank you, Dr. Laure DeMattia. I am excited to share this with folks, and I would love to follow up with you again and even go down some of the topics we didn't have a chance to really dive into.
I would love that. Thank you so much.
Thank you.